Now, I request the dignitaries to light the lamp. Distinguished delegates, ladies and gentlemen, it gives me a great pleasure to extend you a very warm welcome on behalf of the Department of Pediatrics, S. Nijalingappa Medical College, Bagalkot, and IAP Bagalkot branch, who has clubbed all of us for this CME on the art of pediatric practice. We shall start the event with the first lecture. Ladies and gentlemen, may I now request our first speaker of the day, Dr.Promod Jog, to deliver his presentation regarding pitfalls in management of pediatric infectious diseases. Dr. Promod Jog. He is a professor of pediatrics, D.Y. Patil Medical College, Pune, is a director of MediPoint Hospital, Pune. He was an executive board member of IAP from 1992 for 10 terms. He is also a vice president of IAP Infectious Diseases Chapter for 2013. He is a coordinator of Art of Pediatric Practice program of IAP. He has won Plotkin Prize in Advanced Course in Vaccinology at France 2011. He is a convener of full-day workshop on how to be a successful practitioner at Pedicon 2014.
Okay, good morning friends. We will start off with this CME on the art of pediatric practice, and the first lecture is on pitfalls in the management of pediatric infectious diseases. As you can see, if you take the initial alphabets of pediatric infectious diseases, it comes to P, I and D. So I call it as pitfalls. Okay, so you can just relax and listen to the pitfalls. At the bottom you can also see Dr. Jog's name written with all the degrees, and remember, the real meaning of the degrees is known to you, but the other meaning of all the degrees we must be aware of. So as we start and enter into the practice and continue to practice, the word MD turns into mentally dull. Okay, DNB becomes diagnosis not bothered. FIAP is an honor given by IAP, but slowly and gradually it becomes a pediatrician who is famous for irrational antibiotic practices. Okay, and that last MRRP is the real degree which he should try for, and that is, medical representative resistant pediatrician. That is the real degree which we should aim at. But usually what we get is a degree called MRTP, that is medical representative trained pediatrician. Okay, because as days advance, usually medical representatives are the one who start giving us knowledge of various infectious diseases and other pediatric illnesses also. This professor of pediatrics at D.Y. Patil Medical College is not to be altered, because that is my bread and butter. Okay, so now, as I told you, this particular talk is for IAP members. IAP, the real meaning of IAP, but the lecture is for intelligence wise average pediatricians. Okay, so we are all intelligence wise average, so you relax and listen. See, what happens is, as we go into practice, or maybe when we go into the medical college after passing out MD, we get divided into 3 different categories. The first is highly intelligent pediatricians. They are the ones who can diagnose relay day syndrome in a child who has pyrexia of unknown origin. They can diagnose candida ophthalmitis in a child with dengue fever who is not responding at all. So, there are people, they are highly intelligent. We are not going to be in that row. The other ones are LIP, they are the low intelligence pediatricians. I also call them as, CRPs, that is chronic repeater pediatricians, also known as BMR, that is basic mein rada. Basic mein rada, I don't know anything in the basic, so that is BMRs. But our discussion will be related to IAP, and the number of pitfalls, that is the mistakes that are committed by a pediatrician, usually are proportional to the MIC value. MIC is the minimum intelligence concentration. Okay, it is not the pharmac MIC, this is minimum intelligence concentration. So more the MIC, then more the or lesser the pitfall. So you can just remember. Another thing is, now let us imagine that we are all sitting in what is called as an infectious disease OPD. Okay, and Dr. Jog is the head of this intensive infectious disease OPD. Dr. Subramanya is one of my consultants, Dr. Ashok, Dr. Bhuvaneshwari, all of us are, sitting in an OPD, and everyone has been assigned some particular job of examining the child. And before we start and have the patients in this OPD, let us first see as to what are the various reasons as to why people commit pitfalls. This is very important. So the first reason is, of course, H. H stands for the habit. I once went to Bangalore when I was doing my DNB. That was long back in 1985, and opposite that medical college, there was one Kamat's restaurant where I ordered for 2 idlis. And when the fellow brought the dish, just as we had idlis and vadas today, I had ordered, 2 idlis in one plate. He brought 1 idli, 1 vada, idli vada. So I asked him, why are you bringing idli vada? No, sir, it's a part of our habit. Whenever somebody says idli, we bring idli vada. Similarly, whenever we want to give ampicillin, we give ampigenta. Okay, that is idli vada. There is no need of that genta in that. But idli vada. So add ampi, immediately genta. So that first H stands for habit. So please remove that idli vada concept from your mind. If it is ampi, then only ampi. Remember, that is number 1. Number 2, that I stands for ignorance. Many pediatricians slowly and gradually they stop learning, stop reading, and that's why they do not know what is the drug of choice for that particular illness. So what they do is that they put some basic antibiotic like ampicillin, then they add gentamicin, no response, add cefotaxime, no response, add piperacillin, tazobactam, meropenem. The ladder goes on increasing. This is, what is called as ignorance. I call them as Hanuman pediatricians. Hanuman, when, he never knew as to which vanaspati would act on Lakshmana, he lifted entire Dronagiri and brought it for curing Lakshmana. So that is what, is the meaning of the word ignorance. So remember, these are Hanuman pediatricians, so beware of that. So they are the ones who can commit mistakes and give antibiotics irrationally. The third, P stands for panic. If I don't give antibiotics, some of my neighboring pediatrician will give antibiotic, the child will get cured, I will lose my patient. That is a panic. Okay. And these days I was just talking to our colleagues yesterday night. There is lot of pressure by these IT parents. IT, this information technology. At my place in Pune, and I am sure Subramanya at your place in Bangalore, so many IT parents have come. I call them not IT parents, they are the inquisitive and troublesome parents. They will bring, a laptop like this and sit in front of me for half an hour, not less than half an hour. Then the woman will start looking at her mobile, then she will ask one by one all the queries. They will ultimately pay only 100 rupees, but ask almost 150 questions, okay? So it comes to 75 paisa per question or something like that. So it becomes a big tough task to handle these IT parents in the real practice. So I am trying to tell you is that, the other day there was one small little child and parents, they came. I had prescribed them Noamox, Vicoril and Crocin, something like that. So, when I wrote Noamox, I said, no, prescription is over, now you better go. That is what I was thinking in my mind. They never went. So the laptop was still open. So I said, now what next is the step of this gentleman? So he typed NOVAMOX on the laptop. Then he found out the real name, amoxicillin. Then he found out side effects. Then he said, what is antibiotic associated diarrhea? And my viva was going on antibiotic associated diarrhea. So, I will tell you, these parents are horrible. And if you come across these people, I will tell you how to handle them little later. Okay. So now this is that pressure from the IT parents. The child gets fever at 9 a.m. and they come to you at 9:20. And I asked him how long the child has fever. 20 minutes he has fever. So they are the parents of that category. So beware of them. And that last E stands for a trip to Europe. Many pediatricians give antibiotics because they are sponsored for some trip to Italy, Milan or somewhere, and then they are supposed to prescribe Europenem instead of Meropenem. Okay, so that E stands for a trip to Europe. So we should remember that these are the usual causes of, irrational antibiotic practices in our practice. Okay. Now the real culprit who starts, or rather what you may say, adulterates the pediatrician is the obstetrician. Remember, you all know that females usually, bigidify the males in life. So obstetricians are the ones who create a problem. How do they do that? This is because when, they conduct this cesarean section, at that time, before the child cries, they have decided that this is a caesarean, that means I am going to give antibiotic. Okay, so they are already fixed about either ampicillin, gentamicin. So I call them, they get a degree of DGO, that is diploma in gynec obstetrics. Later on they turn into AGOs, that is ampigenta obstetricians. Some of them turn into CMOs. These are the cefotaxime micacin obstetricians. Okay, so they change their degrees very often depending on the antibiotics they use. And before the pediatrician, can think of anything, they have already started. If the pediatrician doesn't start, they will order him to start. Or if he leaves the hospital, they will start it afterwards. But they want to start antibiotic because they say we don't want to take a risk. Who is going to face the music, you or me? Then Dr. Jog says, madam, you. So then you listen to me, don't say anything. So they are not interested in doing that sepsis screen and CRP. These are all words which are foreign for them. So remember, they are the ones who create problem. I told you that every caesarean is not an indication for ampigenta. Please remember, because you are supposed to do many procedures with clean hand and clean surgery. That is one. That what are the pitfalls in this antibiotic therapy in the neonates? Number one, they give it only for 3 to 5 days, which is not a case at all, except for a child with probable sepsis, where the CRP comes negative for the second time. When we discontinue antibiotics, usually there is no need. Number two, giving antibiotics intramuscularly. First, giving 3 to 5 days. Secondly, giving it for 3 to 5 days, that too intramuscularly. So that is another pitfall. And giving this cefotaxime, remember, it is known that when you use third generation cephalosporins, the incidence of extended spectrum beta lactamases increases. And that is why you should keep away from using cefotaxime and third generation cephalosporins in the neonatal period. So please remember, keep away from this. We will not discuss much about neonatal sepsis, but we will go little further. Okay. So now let us imagine that there is a neo-rich mother from IT sector, as I told you, who has come to your clinic, and she is really upset because the child is running fever. She cannot attend to her duties today, and she is really very, very hot mentally. And the pediatrician also is excited as to what I can do for this particular lady who has come to my clinic right now with the child having fever. Now the first thing that we must know is that ask for 2 symptoms. Usually fever and cough are like twin brothers. When your mother usually comes for a fever, we ask, does he have cough and cold? So she says, yes, he has fever, cough, cold. For them all are equal. But we must differentiate at this first moment itself. If there is high fever with grunting at night and high fever, usually it goes into the field of low respiratory infection. But if there is mild fever with bad cough, how much is the fever? Not very much. Cough, very bad cough. Then it goes in the field of hyperactive airway. So you decide that this lady, comes with hot, head, with the child having high fever and tachypnea and all, probably infection. But bad cough, mild fever, usually infection is less likely, hyperactive airway is more likely. So there only you can decide, and whether, you need to give antibiotics or no, that you can decide. That is number one. Number two, if you auscult and if you find that there is wheezing, then usually it is not bacterial. Usually, these are all usual stories. Out of 100, 95 won't have infection, wheezing, because that indicates usually respiratory syncytial virus or something. Number two. Number three, this particular fever, whenever you get fever, you must first of all know as to how to fever without focus. Fever without focus. So we are in the mood of finding out what is the cause of this particular fever without focus. And another thing which you must remember, that all these fevers are not because of infections, and all infections do not produce fever. That is also important. Say dengue shock syndrome, day 5. The child had dengue infection, but he is in shock, so he doesn't have fever. Okay, and non-infectious fever, which you are very well versed with, like thyrotoxicosis or malignancies, where child doesn't have infection, but the child still has fever. So the first thing you must remember on day 1 is thorough clinical examination from top to toe. Now remember the alphabet T, okay? That is the thorough clinical examination from top to toe. So what are these various points in exam? Before we proceed, I must tell you as to what is the correct way of measuring the temperature, because that is one of the commonest pitfalls. Pitfall before measuring temperature is not to have a thermometer. I have seen some pediatricians, some thermometer presented by some medical representative usually breaks, and then he doesn't bother to purchase the new one. Okay, so remember, that is very important. Bring a set of 2-3 good thermometers and keep there. Suppose this is the thermometer. What many of us do is that we put this thermometer, so the mercury end of the thermometer is out of the axilla and it is measuring the atmospheric temperature. Okay. So whenever you are measuring the temperature of any child, please remember that the mercury end, it has to gossify in the axilla like this. Okay. Keep it like this, hold it like this and keep the hand like this for 5 minutes. Okay. Don't compromise on 1 minute, 3 minutes and 5 minutes. The longer the period, the chance of you detecting hypothermia are supposed to be more. That is why you are supposed to keep it longer. Okay. Otherwise in a minute you can diagnose 105 degrees. There is no problem. But in a neonate, if you keep it longer, then if it doesn't rise beyond 95, it really means that the child has hypothermia. That is TPR, BP and CRP. That TPR you all know. T stands for temperature, pulse, respiration, blood pressure and CRP. Now that CRP is something, that is, you should know, that is called as capillary refill. And capillary refill in case of babies, you can do it either on the sternum or you can do it on the forearm. And you know that if it is more than 3 seconds, then you are worried whether this child has some sign of toxicity. We will come to it again. Okay. Second T stands for the tense fontanelle. If a child, that is particularly an infant, has a tense fontanelle, you are worried about meningitis. Come down. I am just giving you a sequence of examination on day 1. Next is throat. Okay. The throat is an important part of examination. That is why you should use the tongue depressors which are of good quality. Use good quality plastic tongue depressors. You know, many of us, again, somebody gives a gift of those, you know, chocobar sticks as tongue depressors which are broken at 100 places. You put it inside and then the child starts bleeding. When you take out the tongue depressor, the mother looks at the blood and she says, what is this? You are practicing for so many years, you still cannot examine the throat also. So many problems. So don't use, you know, those bad quality tongue depressors. Always try to examine the throat with good quality tongue depressors. So put it, and remember, the throat exam gives lot of information. Many of us, what we do, we examine the throat as a pretext for starting antibiotics. That means the throat is red, means suddenly you can, you know, start antibiotics. That is not so. Red throat is not equal to antibiotics. Remember that. We will see that again. Number 2, if there are symptoms like, you know, drooling of the saliva, of the child is toxic, then you have to remember that there is a condition called epiglottitis, about which you should be worried, because sore throat can be a manifestation of epiglottitis also. If there is a parapharyngeal space infection, then also the child can present with sore throat. And if the child is really toxic, then you should be worried. So do not go with an idea that the child has sore throat and red throat means he needs antibiotics. He could be either serious or it could be viral also. Secondly, auscultate first and then go for the throat exam. You know, this putting the tongue depressor and examination of the throat is something which irritates the child, and then he starts crying and all your chest findings are gone. So when the child is in a good mood, you know, with the on the arm of the mother, then only you auscultate and see that the child has been properly examined as far as the chest is concerned. So in the sequence, first auscultate and then examine the throat. Then you come to tympanic membrane. After throat, you put a habit that you will immediately go and examine the middle ear, that is the tympanic membrane. This is very important. It is said that you should examine twice the number of ears as the number of patients in the OPD. Suppose one of you who is a busy practitioner and gets minimum 50 patients every day, so multiply 50 into 2, because every child has 2 ears. So 50 into 2 is 100. So 100 ears every day multiplied by 7 days of the week, that comes to 700 ears every week multiplied by 52 weeks of the year. So whatever that figure comes to. Okay. So many ears you are supposed to examine. I am sure none of us usually does this, but at least keep something in the OPD which looks like a otoscope or something which looks like. In the beginning of practice, I had kept many things, but horoscope was missing. Then at that time I used to use fundoscope, laryngoscope, anything, because the parents don't know what our horoscope looks like. They only, you know, those NRIs, those who come from US and here, they always want that Dr. Jog examines the ear properly and the middle ear. Unless you examine, they are never satisfied. You take an example of any NRI. You know, NRI, the full form is, you know, in my Maharashtra they call it NRI. You know, the parents are waiting for him when he is going to come. NRI means he is going to come. So that is NRI. So that NRI usually wants 2 things. One is Dr. Jog washes the hands properly before examining my child, and second is examines the tympanic membrane. Now why that habit? I found out the reason, because in US also pediatricians want some pretext to start antibiotics. So when they said the drum is looking like this and there is fluid and all, then they can start amoxicillin. Otherwise they also cannot start antibiotics. So here also, but remember, you must have something which looks like horoscope. Just keep the lighter part apart, keep a real horoscope. It gives lot of information about the status of the child. So that is our tympanic membrane. Okay. Then the tender cervical nodes. In case if you find that there are beads of pus on the tonsil and tender nodes, that is the place where you can start antibiotics on day 1 also, no problem. Tachypnea, that is the respiratory rate, less said the better. But remember, measuring respiratory rate is not an easy job. In an older child it's okay, but you have to bend down to the level of the bed. If the child is sleeping, go down like this and see the movement of the abdomen, not from the top, otherwise you cannot examine properly. Tender abdomen, liver and spleen, whether they are enlarged. Then our friend Totaram, that is the genitals in case of a child, I call it Totaram. And then also remember, you can turn the child on the back. The other day there was a small child who had persistent cry and fever. We were not able to find any focus because nobody had examined the child properly. So all that TT went down, and ultimately we turned him on the back, and there was a huge cellulitis on the back, and the child was crying because of that. So once in a while you may come across